My name is Dr. Emily Germain Lee from the University of Connecticut School of Medicine and Connecticut Children's. As Vice President of the Human Growth Foundation, I'm delighted to introduce the second speaker for our series of 7 bone disease webinars. Today, I have the great honor of introducing Dr. Karen Weiner, Director of the Pediatric Endocrinology and Bone Programs at NICHD. Welcome, Karen.
Thanks once again for the introduction, Emily, and thank you to the Human Growth Foundation. So hypoparathyroidism is the only classic endocrine deficiency state not treated with replacement hormone. It is a rare disease of chronic hypocalcemia and hyperphosphatemia due to a deficiency of circulating PTH. Main clinical symptoms are tetany, muscle cramps, seizures, which is also referred to as neuromuscular irritability. The etiology of hypoparathyroidism can be divided into acquired and inherited forms. Anterior neck surgery, also called post-surgical hypoparathyroidism, is the most common cause of acquired hypoparathyroidism and is responsible for about 75% of adult cases. Hypoparathyroidism in children is usually due to genetic variants, and post-surgical etiology is rare in children. Listed here are genetic variants causing defects in parathyroid gland synthesis, gland development, PTH synthesis or secretion. Almost all of these were discovered within the past 2 decades and are still being described. These 2 groundbreaking discoveries marked the beginning of our understanding of the pathophysiology of 2 distinct types of hypoparathyroidism. The first paper in '94 described hypocalcemia from an activating mutation of the calcium sensing receptor. And the second in '97 described mutations in the AIR gene causing APOSED. So autosomal polyendocrine candidiasis, ectodermal dystrophy, APOSED, and autoimmune polyendocrine syndrome, also called polyglandular failure, APS1, are the same disease. This is a monogenic autosomal recessive disorder caused by mutations in the AIR gene, which is expressed in the thymus. And this figure shows all the potential comorbidities, including multiple endocrine deficiencies, lung and liver disease, and chronic malabsorption, which is present in about 80% of the patients. This is a picture of one of my patients who had the classic triad. He also had a brother with the disease, and also they both had biallelic AIR mutations. And you can see several of the very typical clinical manifestations of the disease right in his face. He had vitiligo, which you can see around the eyes, and also, which is an autoimmune process in the melanocyte. And also what's interesting is that he's generally hyperpigmented, which is because his ACTH levels were extremely high because he was malabsorbing his glucocorticoid, which is treatment for his Addison's disease. He looked much darker than the rest of his family members. The other thing is his enamel dysplasia of the teeth. And this is shown here in this figure as well, a very typical feature of APOSED or APS1. Most of our patients presented with non-endocrine manifestations of the disease. So this, what we call the adjunct triad, urticarial eruption, you can see here in this 1-year-old child with APOSED, this raised erythematous rash, very diffuse throughout the body. Also intestinal dysfunction, enamel hypoplasia. And this, in addition to the CMC, hypopara, and adrenal insufficiency that we all know and use to diagnose this disease, we actually propose that the non-endocrine, this adjunct triad, many of these disorders will present early, much earlier than the classic triad. So we propose to expand the classic triad to include any two of the these clinical manifestations, the classic and adjunct triads, as criteria for clinical diagnosis. In addition, all 35 patients from our initial cohort, all but one is shown here, who did not have a biallelic AIR mutation. But all the patients literally had interferon omega antibodies, positive interferon omega antibodies. And so this is another very good way, an excellent tool for diagnosing this disease. These are very, very helpful. And theoretically, all these patients in red do not have biallelic mutations. Theoretically, all should have biallelic mutations, as it's a recessive disorder. Here is a patient of one of my patients, a girl from a long time ago, a girl in red on your left, with her unaffected, healthy twin sister during her first admission to the NIH 25 years ago. And here she's shown as family H with a missense mutation in the transmembrane domain. And what was interesting about her, she was, first of all, one of the first children to be identified with the calcium sensing receptor, activating mutation in the calcium sensing receptor. She was unusual also in that before this time, the disease had been described as very mild, needing minimal or no intervention. But this girl and many others in my cohort had severe hypocalcemia presenting with seizures, renal insufficiency, and nephrocalcinosis. We recruited 21 of these patients with activating mutation of the calcium sensing receptor, also referred to as autosomal dominant hypopara, because that is how it's transmitted. Nephrocalcinosis is very prevalent, and also renal failure. There's a very high risk of renal failure. 4 of our patients had renal failure. Now, the figure on the right demonstrates, just comparing post-surgical hypopara with the patients with a calcium sensing receptor. The calcium sensing receptor patients have urine calcium levels much higher, significantly higher than the post-surgical patients do, with a similar level of serum calcium. And this is an overview of the regulation of calcium homeostasis. PTH is released from the parathyroid gland in response to a decrease in extracellular ionized calcium levels, enters the circulation and acts on the PTH receptor in bone and kidney. PTH has a direct effect on the bone to enhance bone resorption, on the kidney to stimulate calcium reabsorption and phosphate excretion and vitamin D synthesis. And calcitriol, which is activated vitamin D, has a direct effect on the GI tract to absorb dietary calcium and phosphate. So as I said, PTH stimulates the formation of active vitamin D in the kidney, and therefore PTH therapy provides the benefit of both hormones, PTH on the kidney and vitamin D on the GI tract. In my studies, PTH was used alone and was not used in adjunct together with calcitriol and calcium, which is conventional therapy. And in order to really get the most benefit out of PTH therapy, one must maintain normal 25-hydroxy vitamin D levels, and the patient must take adequate dietary calcium intake. Conventional therapy for hypoparathyroidism consists of calcitriol, calcium supplementation. But conventional therapy does not restore the PTH actions on the kidney and is associated with adverse outcomes such as kidney stones and nephrocalcinosis. There are two forms of PTH that have been available and are still available. The first is in 2002, recombinant human PTH 1-34, Forteo, was approved for osteoporosis. Many physicians have used this off-label for hypoparathyroidism in both adults and in children. In 2015, PTH 1-84, recombinant human PTH 1-84, also called NatPara, was approved for refractory hypoparathyroidism, and this is used in conjunction with conventional therapy. This, however, was recalled in 2019, is currently not available, and they recalled it due to a defect in the rubber stopper, so they need to address this issue if it's to come back on the market. There was no available PTH available to us in our studies early in the 1990s when we began our studies. Synthetic human PTH 1-34 was formulated for our studies at the NIH pharmacy. Over 2 decades, we studied single daily, twice daily subcutaneous PTH injections in pump delivery and ultimately pump delivery of PTH first in adults and then replicated in children in studies lasting up to 10 years. So with each study, we sought to further refine PTH replacement therapy of hypopara and adapt to individualized needs of the patient. Most published patient cohorts study predominantly adult women with post-surgical hypoparathyroidism, because as I said, that's 75% of cases of hypopara. The larger multi-center trials have actually excluded patients with the calcium sensing receptor mutation and also have excluded children. We studied 192 patients over a 27-year period. Only 25% of the group had post-surgical hypopara in my cohort, and half the cohort were children. There were a large number, the majority of the cohort was genetic forms or familial idiopathic hypopara. Baseline studies on calcitriol reflect the difference between the etiology groups in terms of the propensity to calcifications. Half the patients who had imaging at baseline had evidence of renal or brain calcifications. So for example, the calcium sensing receptor patients, the activating mutation of the calcium sensing receptor patients, 100% of them had nephrocalcinosis, and 80% had brain calcifications. And similarly, the APOSED patients, 60% had renal calcifications of those who had imaging at baseline. And brain calcifications, half of them did. But it's interesting, the post-surgical cases, only 20% had renal calcifications, and this is very similar to what most of the other published cohorts report, that it's about 20–25% with renal calcifications. And none of them had brain calcifications. Our initial study examined the effects of a single daily PTH injection, which is shown here in red. And that's compared to conventional therapy, calcitriol, and calcium. And this is in 10 adults. It's a randomized crossover design. So each patient ultimately got both treatments. The data confirm the well-known physiologic effects on the kidney. There is an immediate and rapid rise of calcium, phosphate, and urine cyclic AMP, and also a decrease in urine calcium excretion levels. But if you look at this more carefully, the urine calcium excretion is a biphasic response and reflects two opposing effects occurring sequentially. The first one would be from the calcium sensing receptor mediated rise in urine calcium excretion. And this mirrors the concurrent acute rise in serum calcium. And this occurs very early on. These are every 30-minute measures that we did. So we caught this very early. The second is the PTH-mediated rise in tubular calcium reabsorption, which reduces urine calcium excretion. The initial rise in urine calcium excretion, however, even though it is transient, may be clinically significant if the PTH dose is too large and the urine calcium levels are consistently above the normal range for each PTH injection. So then this observation led us to reduce the PTH dose by increasing the injection frequency. This figure shows the difference in the response related to the etiology of hypoparathyroidism comparing once daily and twice daily PTH. We were able to reduce the daily dose of PTH by half for the BID PTH injections compared to once daily dosing. There is a significant difference in the pattern of response for both etiology, comparing daily and twice daily. First of all, there's a significant improvement in the mean calcium level during twice daily PTH for the calcium receptor mutation patients. It looks quite low, but this is actually a level that is very comfortable for them. They have no symptoms at a level of between 1.8 and 2 millimoles per liter. And most of them, this is where I titrate this group to. And there is also a difference in the pattern, daily versus daily, once daily versus twice daily, for both groups in looking at the different treatment regimens, daily versus twice daily. And also there is a you can tell for the post-surgical patients that the twice daily group yields a very kind of more steady state, normal level of serum calcium. We achieved our goal in normalizing both urine and blood calcium in the acquired and idiopathic group, but not in the calcium receptor group. So these urine results show a significant difference in the pattern of response in the once daily versus twice daily. And you can see the magnitude of the response is much more exaggerated in the calcium receptor group. And this is much more obvious in the looking at the cyclic AMP. You can see the open circles is the once daily and the closed circles is twice daily compared to the acquired and idiopathic group here on the right. And it's also interesting to note that for both serum and urine calcium, 6 to 8 hours after the injection is when we achieve the highest levels of both serum and urine calcium. So based on what was learned in the short-term studies with once daily and twice daily PTH, we initiated studies with twice daily. But let me just recap what I said before we go to the twice daily studies that we did. So first of all, this is what I just had mentioned to you: reduced total daily PTH dose in most cases. The increase in frequency of PTH injection reduces the total daily PTH dose in most cases at least 50%. And also, increasing the frequency of PTH injections leads to much reduced fluctuation in serum calcium level, especially in the idiopathic and post-surgical group, and a decrease in urine calcium excretion levels for the acquired and idiopathic group. But we did not achieve that in the calcium sensing receptor group. So this shows the response to twice daily PTH injections, and this is broken down even further according to etiology. So here I'm showing you pretty much all the etiologies. The APS1 group is in red, the calcium receptor group in green, post-surgical group in blue, and this combined, which would be the idiopathic familial group of patients, here is in purple. So the main thing that I wanted to show you is most of these patterns. So we look at this in two ways. We look at it in terms of sort of the circadian pattern over a 24-hour period. And you can see that for the most part, this is for all the etiology groups, these patterns are very similar. There are differences, which I'll point out to you later. The difference in the mean levels is actually more obvious in the calcium receptor group, who have significantly higher urine calcium and magnesium levels. And you can see that here. And let me just show you. Also, before I go to the next slide, the APS1 group here also have consistently higher urine calcium excretion compared to the post-surgical and idiopathic groups. And this may be due to the fact that this group of patients, most of them, the vast majority, are on chronic glucocorticoid therapy for Addison's, for pneumonitis, for hepatitis, for other comorbidities that they all, it's part of their disease. And this is the same data as in the previous slide, but now showing just the post-surgical and the activating mutation of the calcium sensing receptor groups. The post-surgical had normal urine calcium. You can see that here, it's very obvious. Normal urine magnesium. The patients with the calcium sensing receptor mutation have excessive urine calcium and magnesium, as I said before. And this is because both calcium and magnesium are receptor agonists, and therefore the handling of both calcium and magnesium in the kidney is disordered in this disease. And the other thing I just wanted to point out too is that although the patterns are seen very similar, if you just juxtapose the post-surgical with a calcium sensing receptor, so the calcium sensing receptor here is in red and the post-surgical is in blue, you can see that these two patterns are definitely different. And again, the magnitude of these excursions, as I showed to you earlier in the adult patient, that smaller study, the magnitude of the excursions are much greater for the calcium sensing receptor group compared to the post-surgical group, which really has a much more steady state pattern of calcium. The contrast among the etiology groups remained apparent also over a 3-year period. It is interesting to note that the post-surgical group has normal, simultaneously normal, this is in blue, serum calcium and normal urine calcium. However, the other two, the APS1, which is in red, and the calcium sensing receptor, which is in green, you can see how the calcium sensing receptor, they remain at this level. This is where they're most comfortable, around 1.8, 1.9 or so in millimoles per liter for serum calcium. And they hover in the high and even above normal range for urine calcium. So to further refine replacement therapy, we turn to pump delivery of PTH. And we use the Omnipod pump, which is made by Insulet, and put PTH into the reservoir instead of insulin. And we didn't change the pump at all. It would just use mainly the basal rate option. Shown here is PTH secretion in normal volunteers. Normal PTH physiology is characterized by small pulsatile bursts. You can see here, about 5 an hour, so every 12 minutes, with an overall circadian variation. Acute hypercalcemia suppresses the pulsatile secretion. Here is with an external IV calcium. But there remains this constant sort of tonic, low-level PTH secretion, these little sort of oscillations. So PTH never really goes down to 0. So with this in mind, we hypothesized that the insulin pump would be an ideal tool to mimic normal physiology. The pump delivers set microbolus and microliter amounts given at programmed intervals throughout the day, similar to how we program basal rates for insulin delivery in diabetics. This is an example of one of the basal rates for an adult patient with post-surgical hypoparathyroidism who received just 3 pulses an hour. She received the lowest dose. And most patients of mine received 4 or 5 pulses an hour. So this represents 7.2 micrograms a day. Each pulse is about 1.1 microgram. Here are the results from the randomized crossover study of pump versus twice daily PTH injections in adults with post-surgical hypoparathyroidism. Both injections and pump delivery produce normal serum, calcium, magnesium, phosphate levels, with significantly reduced urine calcium by about 50%, you can see here. And also there's about a 65% reduction in the PTH dose during pump therapy. So similar to what I described, going from once daily to twice daily, going from twice daily to the pump, there's a significant dose reduction. And you can see the data in black or the pump data right here. In the same study in post-surgical adults, these 8 adults, these are the repeated measures of urine excretion. There's a significantly less fluctuation with pump delivery. Again, this is shown in the black circles. And that's true for the other analytes, not only calcium, but magnesium, phosphate, and cyclic AMP. You have very steady state levels of those. So PTH binds to its receptor. It's a G protein coupled receptor in the kidney. And the patterns of urine cyclic AMP excretion generated in response to PTH 1 to 34 delivered by pump compared to sub-Q injections reflect two very distinct levels of PTH receptor activation. PTH injections resulted in a rapid but transient rise in urine cyclic AMP levels, which immediately return to baseline. But PTH delivered by pump maintains sustained level of cyclic AMP above baseline throughout the day. So given the significantly low levels of urine calcium excretion, one can conclude that the renal tubule must be continuously exposed to PTH to sustain its calcium conserving effects. So then we turn to the more difficult patients, the patients that I described before, the APS1 patients and the calcium sensing receptor patients. And pump delivery of PTH was highly effective in children and adolescents with APS1 or with calcium sensing receptor mutation. We observed that pump produces normal serum, shown here, serum calcium shown in black, and urine calcium levels with no or very minimal fluctuation. And then just to further illustrate my point with increasing injection frequency going from once daily PTH, where we gave doses of about 1.4 microgram per kilo, you can see relatively large excursions, which come down and are reduced with lower dose during more frequent injections, twice daily injections. But then finally, with the pump, PTH is delivered in these very tiny microboluses throughout the day, and they're constant. And this is essentially produces no fluctuation in urine calcium excretion. So we concluded that pump is the best method known right now of delivery that best mimics normal PTH physiology. Many patients with hypoparathyroidism also have hypomagnesemia. PTH effects on serum and urine calcium, as I mentioned before, are similar to PTH effects on serum and urine calcium. Patients with a calcium receptor mutation are more profoundly hypomagnesemic because the calcium receptor binds other cations such as magnesium and sodium. And so this shows magnesium data from two different studies in children. This shows the difference between once daily PTH versus twice daily. So the once daily here is in the open circles, twice daily in the red circles. And this is in just comparing once daily and twice daily in this group of patients. And then looking at the twice daily, which is shown in blue here, I'm sorry, it is shown in the open circles versus the blue, which is the post-surgical, the pump data. This shows the difference that the pump is able to maintain serum calcium in the normal range. And also, it's interesting, these patients there are 7 patients here with calcium sensing receptor, and most of them were able to come off their magnesium supplements. In children with APS1 or calcium sensing receptor, twice daily injections, which is shown in white, produce bone markers in the high or above the normal range. When PTH was delivered through the pump, though, this is data shown in black, the markers of bone turnover were in the mid-normal range. And this suggests that pump therapy is more physiologic for the bone compared to injections. This report from France and the UK was recently published 2 years ago, described the long-term use of pump with Forteo. And so they used, in a very similar fashion to what I just showed you. And there are here 3 APS1 patients and 1 with idiopathic hypoparathyroidism. All 4 patients had malabsorption, and the ages were 8 to 13. So PTH was given by pump between 3 and 8 years, and this shows the follow-up just over a 24-month period. And what they show is a normal serum calcium level, normal phosphate level, and they say that this normalized within 48 hours of initiating the therapy Forteo using a pump. And also they report as well a very significant decrease in hospitalizations, and also 100% of these patients, all 4, express preference for the pump over conventional therapy. This figure demonstrates the reduction of alkaline phosphatase levels, a marker of bone formation, in adults from frankly high levels to the mid-normal range as we progress from once daily, shown in the black bars, to twice daily, and then to the pump, shown in the blue. As you all know, alkaline phosphatase is a marker of bone formation. So as the dose decreases and as injection frequency increases, the markers of bone formation go from high normal to the mid-normal range. Here is a long-term observational study of 14 children with either APS1 or a calcium sensing receptor. All patients received twice daily PTH 1 to 34. Several of them had brief periods of thrice daily injection, especially in the APS1 patients when they develop severe malabsorption. Compared to reference norms, this group of 14 children had normal linear growth, and you can see that here on the left-hand panel. And also they had normal bone accrual velocities, and these are Z-scores. And this is lumbar spine here, the whole body hovering all around a Z-score of 0. So these are normal linear bone accrual velocity. The first year for the radius, the bone accrual velocity was suboptimal. and that they caught up later on in subsequent years. So in summary, genetic hypoparathyroidism due to the calcium sensing receptor, or APS1, are often refractory to conventional therapy and have a high rate of nephrocalcinosis. Normal serum calcium and urine calcium excretion can be achieved with twice daily PTH in the post-surgical hypoparathyroid patients. Twice daily PTH produces normal linear growth and bone accrual in children. Pump therapy produces the most physiologic profile of serum calcium, urine calcium excretion, and markers of bone turnover. Future directions include the study of long-term effects of pump therapy on the bone and in the kidney in adults and children. I think we really need those data. In addition, long-acting PTH analogs provide steady state levels of PTH consistently normal serum calcium and urine calcium in a very sustained fashion, similar to what we experience in pump. And there are actually two different molecules now that are up and coming. The TransCon PTH is actually in clinical trials right now, and the data look quite good. This was presented at the recent ASBMR meeting. I think they're phase 2 data. And LAPTH also, I think, are planning clinical trials as well. So a blood calcium monitoring device is very important for individualized therapy. This is essential to understand the impact of small dose adjustments that one must make for these patients. And this is just simply not available now. So that's really something that hopefully we'll have in the future.
Thank you very much, Karen, for that really excellent talk. I must say thank you very much as well for all the work you yourself have done in this field. It's really been remarkable. I'm going to start with one of the earlier questions during your talk from Dr. Nancy Dunbar. She has a 14-year-old with a calcium sensing receptor activating mutation that was managed on Natpara. After the 2019 recall, he went on Forteo, but had persistent fatigue, nausea, and headaches. So she switched him back to Natpara. Is that a common complaint?
No, I have not heard that. We have switched between Natpara and Forteo and haven't, it's really, a lot of these symptoms are probably dose dependent. And I would need more information about the dose and how frequently it was given, but it's possible they never achieved the optimal dose for that child and then just went back to Natpara, what they were, more familiar with.
I have a specific question related to just PTH treatment in general. Could you explain the black box warning of PTH and its relevance to the treatment of hypopara, and specifically any evidence of carcinogenic effect in humans?
Yeah, so the black box warning came about initially in the late 90s in connection with their IND approval of Forteo. Eli Lilly presented their rat data, which demonstrated a dose-dependent effect on these rats, causing osteosarcoma in the highest group receiving the highest amounts of Forteo. But, you know, ever since that time, we have, there are other studies, non-human primate studies that have not replicated this. We think that perhaps the rat model is more susceptible, perhaps, to osteosarcomas. And also, one must keep in mind that hyperparathyroidism, which is a constant level of high level of serum parathyroid levels, is not really associated with osteosarcoma. I do think that more data is required in children to maybe lift the black box warning, but I think that that is pretty much the history, and that is why. And also, the same was found for PTH 1 to 84. It's not just PTH 1 to 34.
Right, right. Thank you. Dr. Alan Rogel has a question. The long-acting is not pulsatile, so might the dose be higher, perhaps by a lot? And what do the preliminary data show in this regard?
The long-acting, the Ascendis, the TransCon is not pulsatile. That's right. It's no, it's I don't know exactly what the doses are, but I think one can give relatively small doses for this molecule and achieve that very steady state result. I'm not sure if I'm answering Alan's question, but I think that's what you're asking, if you need high doses for the TransCon PTH to achieve the same thing. And I don't think so. I think they're planning on giving, and they have given, very low level doses, and which have demonstrated this very nice calcium normal steady state profile over a 24-hour period.
Okay, thank you very much for that one. So there's another question here about, well, from two people, Dr. Gaffney and someone else, about the hypercitraturia in your studies with PTH.
The hypercitraturia. I didn't have excess citrate in my studies. I did measure some of the patients. Most of the patients had normal citrate excretion. You have to understand, though, that the patients on the conventional therapy, many of them do receive calcium citrate, calcium acetate. When they go to their renal consults, most of them will put them on that to prevent renal stone formation. So when you compare the conventional therapy that has a lot of exogenous citrate, acetate, whatever, to Forteo, not Forteo, the synthetic, because I use synthetic PTH 1 to 34. We had no preservative. We had no acetate or citrate in that. So they are going to get less of that compound. So most of my patients on both conventional and on synthetic PTH 1 to 34 had normal citrate excretion. You know, the normal citrate levels it's a huge range of normal. I think it's like 200 to 1,000. Really wide.
So that, right, that's helpful. I might have misspoken. The person was commenting on Dr. Gaffney's studies with PTH that there had been reported hypocitraturia. This question wasn't also from Dr. Gaffney, sorry. But that answered the question
Okay.
Thank you very much. That was very helpful. There is a question that I think if we skip to APS1, in terms of the testing for that, you had mentioned the interferon omega autoantibody testing. How do physicians test for that commercially?
Yeah, okay. I'm glad you brought that up because it's not commercially available. It's a wonderful test, and the people who study this disease are able to do it in their lab. So I think that the endocrinologists, the physicians out there listening, if you have a patient with APOSED and you're just or suspected APOSED and you're making the diagnosis, you really and you want the interferon antibodies, you really do have to contact one of the investigators that are really studying these, like at the NIH or in Europe, and they could do it for you.
Another question that is a case regarding NatPara. This physician's wondering about a patient on NatPara, initially well controlled, and was well controlled without calcium or calcitriol supplements for almost a year, but now has had several admissions with severe hypocalcemia. And they're wondering whether there's a specific guideline to wean off from NatPara that you'd recommend.
So in other words, they were on NatPara and then they went to conventional therapy.
Right, went to conventional therapy. Right. They had a well-controlled calcium, but really didn't need much in terms of supplements from the way this question was worded until about a year, and then needed admissions because of severe hypocalcemia.
Needed admissions because hypocalcemia while they're still on, but after they switched over to...
After they switched over to the supplements, yes. So with not needing them for a year, then going on supplements is my interpretation. But even on supplements, having it.
Yeah, I understand. I do have some experience with NatPara, but not a huge experience. In my studies with PTH 1 to 34, we switched back and forth very easily between PTH 1 to 34 and conventional therapy. And as I said in my early part of my talk, that it's essential when you're treating patients with PTH that you maintain normal calcitriol, normal vitamin D levels, 25-hydroxy vitamin D levels. And that is really essential. The other thing is, often when you give patients once daily, and I did see this early on in my studies when I gave once daily, you're really hyperstimulating the bone. And so their bone markers are very, very elevated. So when you go from that state where the markers are very elevated to calcitriol, sometimes, yes, you do run into problems. I demonstrated, though, that we actually analyzed this, comparing the patients while they were on calcitriol before starting PTH, and then the levels of calcitriol and calcium after they've been on PTH, the post-PTH vitamin D levels were identical. So the calcitriol and the calcium levels were identical as long as the vitamin D levels remain normal we had no trouble with that.
Thank you. There is another question here. Dr. Dunbar was wondering about the calcium-based phosphate binders versus non-calcium-based phosphate binders like Renagel being used.
I have no, I do not use Renagel. We did not use that at all. I mean, calcium carbonate is sort of considered a phosphate binder, but we did not use that at all. So I can't really comment on that.
Okay. So just one question. I was wondering if you could comment on the specific differences in the formulation between Forteo and the synthetic human PTH 134 that's used at the NIH.
Okay, good. Yes, so that is important. So they're often used interchangeably, and the active ingredients PTH 1 to 34 is pretty much the same. However, you know, the only real difference. Okay, so the synthetic PTH 1 to 34, which was formulated in the NIH pharmacy for us, specifically for our investigational studies, has a 5% mannitol solution. There's no preservative whatsoever. Forteo, the preservative is acetate, which is interesting. And acetate, you know, often, as I said, renal consults, nephrologists will give calcium acetate and other acetate salts to their patients when they want to prevent you know, kidney stones. That would help to prevent. So calcium acetate is given to patients to prevent stone formation. Same thing with Natpara. Natpara has a citrate solution. So I think that is the main difference. I'm not sure, you know, you have to keep in mind that these, there are no head-to-head comparisons in the literature between synthetic human PTH 1 to 34, Forteo, which is recombinant human PTH 1 to 34, recombinant human PTH 1 to 84, no head-to-head comparisons. So any sort of claims say that the differences is really more conjecture. It's not based in any data.
Right. So that was very helpful. Thank you. I'm going to go really quickly back to I'm going to wrap up now, but I want to go back to that person the physician who asked the Natpara question. I may have misinterpreted the question, and they were more specific. So that patient had had several admissions with severe hypocalcemia while on Natpara. And despite Natpara and oral supplements with calcium and calcitriol, still has hypocalcemia. So I apologize. I really appreciate you sending back in a follow-up to that. So the question is, you know, does Natpara effect disappear after a while?
Oh, yeah, that's a tough question given my limited experience with Natpara, and I think that I don't know of any reports where patients have stopped responding to Natpara, but I have to say that I really don't have enough expertise in that area to really respond well to that question.
Yes, and I've had some experience with Natpara, and I also cannot recall reading anything specifically regarding this issue and the effect disappearing. It's a very interesting question. I also, Karen, agree that I don't know if there's data out there or not, but you know, it's an interesting question. So I think that we're going to wrap up now. Thank you so much, Karen. That was really a great talk. I thank everyone who asked questions. They were really thought-provoking questions, and I appreciated all your answers, Karen. They were very helpful to me as well in treating these patients. So I'm going to say goodbye to all. Thank you for joining us. And we are going to now go into our virtual showroom to end this talk. Thank you all. Bye.
Thank you.